more simple. This is the simplest classification of neuromuscular disorders. Either there may be when you use the term myopathic disorders, it is a very loosely applied term in clinical practice. It includes large number of muscle diseases. So for clinician, anything which is related to muscle is a myopathic disorder, which is related to nerves is a neurogenic disorder. This is the broader classification. And in the neuromuscular, in the muscular dystrophy, inflammatory myopathy, congenital myopathy, metabolic myopathy, endocrine myopathies, and there are many more drug-induced myopathies, especially the statin-induced. Nowadays, these immune inhibitors which are given in the PDL inhibitors, all those newer therapy, they are causing the muscle diseases. There are a lot of toxic effect on the muscles. When we use the term congenital muscular dystrophy, it is a muscular dystrophy like any other muscular dystrophy, but it starts at the onset of birth. When we use the term congenital myopathy, this also starts at the time of birth. In both these conditions, the child present as a floppy infant, but in congenital muscular dystrophy, there is destruction of the muscles, there is fibrosis, so there is CPK is very much raised. Whereas in congenital myopathy, creatine phosphokinase is not much raised or it is normal. Secondly, most of the congenital muscular dystrophy are progressive, whereas the congenital myopathies, they are non-progressive or static. They may even improve with time. So this is the broader classification. And how to differentiate between the myopathic and neurogenic disorder. In myopathic, it is mostly the proximal muscle weakness, whereas in neurogenic disorder, it is the distal muscle weakness. There is hypertrophy or atrophy of the muscles, but in neurogenic, it is always atrophy. Fasciculations are absent in muscular dystrophy, but they are present in neurogenic disorder. Reflexes are normal, where they are absent in the neurogenic. CPK is raised. It varies depending upon the subtype or the severity of the disease. Whereas the neurogenic is normal, then come the morphological differences. In muscular dystrophy, this is variation in fiber size, there is fibrosis, there is degeneration of the muscle. Whereas in neurogenic disorder, there is group atrophy. These are the fiber of these which are atrophied. So these are some of the clinical and morphological differences between the various disorders. Now there are two parts of muscle diseases interpretation. One is the interpretation, and from the very when we get the HND slide, we have to make our mind whether this is a muscular dystrophy, whether this is a inflammatory myopathy, whether it is a congenital myopathy or a congenital muscular dystrophy, or is it metabolic. And accordingly, we decide what test to be done, which investigation to be carried on. But we know that after the discovery of dystrophin gene and protein, the large number of genes are discovered, and especially with the NGS now. I think I compared the muscle diseases with the lymphomas, where every day there's a new entities added. So a lot of entities are the number of diseases causing gene is increasing. So it is very difficult to remember. I'll come to some of those points. But the first part is the muscle biopsy. I will say this is the most important. Second part, if the first part is okay, the interpretation is not very difficult in majority of the diseases. At least broadly we can classify. So what are the indications for the muscle biopsy? Sometime earlier we used to do for confirming the diagnosis. If there is clinical suspicion that is a Duchenne muscular dystrophy, they do the muscle biopsy. and we do the test and diagnose this is a Duchenne muscular dystrophy. But nowadays it is not true. There are many other unsuspected diseases, or their clinical features may be overlapping. There may be a lot of differential diagnosis. So these are some of the indication today for the muscle biopsies. Now, what are the commonly biopsied muscles? The quadriceps vastus lateralis is the most common, but in some places people do the peroneus longus when it is to be taken with the nerve biopsy. When nerve and muscle both are taken together, especially for the diagnosis of vasculitis, it increases the yield of the biopsy. In some diseases, tibialis anterior is affected. So some people prefer the tibialis anterior or the posterior, but the calf muscles are not taken because normally also calf muscle they show a lot of dystrophy-like features because they are the overused muscle. Deltoid in some places people prefer the deltoid muscles, and depending upon the nowadays people are doing the ultrasound or the MRI and find out the which muscle is most likely to be biopsied, especially in the inflammatory myopathies, because they are segmental diseases. They involve the part of the muscle. There are different ways. Needle biopsy, we don't perform needle biopsy in India, but people who are in UK, many people are doing the needle biopsy. It is easy to perform. Not a big incision is given. Whereas in the open biopsy, it's an incision is given. There is a pain. It is a painful. It requires local anesthesia, stitching, and sometimes there may be wound infection. So in some places, people prefer the general anesthesia, but for a normal I think in normal procedure, it is not required. One can do under local anesthesia. Now, what are the precautions to be taken? Sometimes some muscles are so severely wasted that they show the end stage diseases. It is difficult to differentiate between the different types of diseases. So it should not be very severely wasted. It should be moderately involved muscle. Sometimes some muscles are not that much affected and they will be normal. So one should be very careful that it should be a moderately affected muscle. One should avoid the site of trauma, needling, injection. For example, before muscle biopsy, people are doing the EMG studies. So they put the needle. So some people do recommend that in a right-hand person, the EMG should be done on the right side and the muscle biopsy should be done on the left side because it is painful for a right-hand person, maybe more disturbing. Injection site, sometime it should be avoided. The muscle should be from the center of the belly. It should not be near the tendon. Sometimes near the tendon, for example, this muscle, this is this group of muscle fiber is showing a lot of internal nuclei. So it look like the muscular dystrophy, but actually this is near the tendon. So one should avoid these sites for the muscle biopsy. And anesthesia should not be injected into muscle. It should be subcutaneous to the skin and not in the muscle because it produces a lot of artifacts. So there are a lot of not to do. Too much handling of the muscles produce artifacts. Stretching the muscle, some people tie with the pins on both ends. Some people tie with the thread and never put in a fixative. We recommend that the muscle should be sent freshly without any fixative. Some people do recommend that as a moist, this gauze in a saline should be wrapped around the muscle if it is to be sent to a little bit more distance. But if it is had to be sent for a long distance, then it should be either in the isopentane, cooled with the liquid nitrogen, or in the dry ice. One can transport these muscles. I think within 2 hours, there are not much changes, but sometimes the enzymes histochemistry may be difficult. The sarcolemmal proteins, they can be demonstrated, but enzyme histochemistry is difficult sometimes. So what are the different methodology what we apply for the diagnosis? Histopathology, histochemistry, immunohistochemistry, immunoblotting, electron microscopy, and genetics. Now, what is recommended that the most important is that is the muscle should be immediately frozen. Be what is known as the quenching. We put the muscle in the isopentane, which is pre-cooled in the liquid nitrogen, and then we put in the cryostat and cut the section for the different methodology. Light microscopy may not be very useful if the muscle is small, but if the muscle is piece is larger, one can put some time, it may help. But by and large, this this fixation in the buffer formalin is not very helpful. Now the other part is the electron microscopy. As we know that for the electron microscopy, the piece should be very small. We used 2.5% glutaraldehyde, and this can be transported to any place. So smaller is the piece, longitudinal it should be for the electron microscopy. Now genetic studies, nowadays most of the diseases which are genetically determined, muscular dystrophy, some of the others, the test can be done from the blood also. So mostly the blood sample is also recommended along the muscle biopsy. This is how we receive the muscle. This is cut in 3 pieces. One for the quenching or the immediate frozen. Other is for the light microscopy. Formalin fix. Other is for the electron microscopy. And there are different ways to improve the orientation. One is the glass, magnifying glass. One can orient the muscle. One can use the stereo zooming microscope. Whatever is available or whatever you person is convenient. Some people even without using these, they embed the muscle without any problem. So after this is the isopentane pre-cooled in the liquid nitrogen, and the muscle is put in this, and it is immediately put in the liquid nitrogen. Now there are different ways. We put in the big cylinder immediately, whereas some people take the liquid nitrogen in the flask or some other this thing, and then fix the muscle in the liquid nitrogen. Now, but I am showing that the position, the status of the person, whether it is professor or not, or some other person, doesn't matter. It is a technique. This is myself. I have put the muscle, fixed the muscles, but this is the result. This is a lot of crystal, ice crystals. So this is no use. So this part, when you're putting in the liquid nitrogen, should be very, very fast and very, very careful. Now there are instances, for example, this I thought there are artifacts, but one of the points which is against the artifact, there are some of the fibers, these one, they are normal, they are fixed well. So why the few fibers should be showing these artifacts? These are the vacuoles actually, and if you see carefully, these are the more paler myofibers. These are the degeneration of the myofibers, and this is the oil redo, which is positive. So this is a lipid storage disorder. And there's on the electron microscopy, one can find these lipid vacuoles, large number of lipid vacuoles. This is abnormal. The lipid under electron microscopy appears as a ground glass appearance. It is not like the water, which is more clear. And these are the sum of the mitochondria. These mitochondria are more in lipid storage myopathies. Very, very rarely we get the paracrystalline inclusion like the mitochondrial myopathy. So this is actually not the artifact. Artifact should affect the whole of the muscles. Whereas the some of these vacuole, maybe these lipid vacuole, sometime it may be the glycogen, which is causing some these vacuoles, and which should be positive for the PS. So this is how to differentiate from the artifact. Now, after putting in this is OCT, where we put the muscle on this, hold the muscle on the chuck, then we cut the sections, and these sections are stored at minus 80 degrees. Some people recommend more than 40 degrees or 35 degrees enough for storage. But when we take out the sections for the later on, there are a lot of these, if it is immediately brought out, there's wrinkling artifacts. So this one should be very, very careful. Now, as I told that there are a lot of methodology, ancillary techniques which can be utilized for the diagnosis, and it depends upon the first look whether this is a neurogenic, myopathic, inflammatory, metabolic, and all are complementary to each other. They are not substitute. One may help, this may be having additive effect, not the substitute for that. This is the normal muscle. In the normal muscle, it is a checkerboard pattern. In the under the HND, this is the darkly stained fiber, more eosinophilic. They are type 1. They have more mitochondria, oxidative, where the type 2, they are lighter. They have more glycogen. So this is the normal Masan trichrome. We hardly find this is the perimysium, this is the endomysium, and the normal muscle, this appears as a unstained areas, very light. And when we do the histochemistry, it shows a checkerboard pattern. ATPase can be employed for the typing of the fiber at different pH, 9.4, 4.6, 4.3, to characterize the 2A, 2B, 2C fibers, but it's not always needed. Large number of stains can be done, or which are routinely helpful in the diagnosis. And MGT, most of the time it should be red. For example, this is the ragged red fibers. This fiber appears red and appears as if it is rubbed off. So these are known as the ragged red fibers. They are very, very classical for the mitochondrial myopathy, but sometimes they can be seen in the inflammatory myopathies. I will come to that. The wild rado, these vacuoles are red. One can use the Sudan black also. The other is Cox negative fibers. These are bluish one. What we do, the cytochrome oxidase, first we apply. The brown fibers are type 1, and the fiber which are lighter, they are type 2. And the fiber which are negative for cytochrome, then we stain with the SDH, and it gives a very good contrast, brown and blue. So this is very good for the diagnosis of mitochondrial myopathies. Now this is the ultrastructure. The muscle is thick filament, thin filament, transverse tubule, sarcolemma, mitochondria, and the reticulum. All these can be studied under the electron microscope. This is the normal Z band, A bands, I bands, and these are the some of the myofibrillary proteins which are binding these various types of protein. Now the electron microscopy, it should be longitudinal. For the HND, we prefer the transverse section. But for the electron microscopy, it should be longitudinal. These are some of the mitochondria. In between, these are the Z bands, and the smaller, these darkly stained areas are this is the glycogen. In the transverse, we can see the thick filament and the thin filament, but it's not very useful. And many times, some of the Z bands or the other things, they appears as abnormal in the transverse section. So transverse section is not recommended for electron microscopy. This is the membrane, cell membrane, myofiber. This is the nucleus. The nucleus of the skeletal muscle in the periphery and the membrane is outside. This is another nucleus which is immediately to the muscle fiber, but the basal lamina is common. For example, this is the basal lamina of the muscle, then going on this is a satellite cell. But the plasma membrane is different. So this is how to differentiate the nucleus of the muscle from the satellite cell. Now, sometime if it is not possible, sometime we can do the immunohistochemistry. Now, a lot of antibodies are available. CD56 is positive, 34 is positive, nestin is positive. There are many stain packs. 7 is transcription factor is positive. So one can study the number of the satellite cells. The interest in the satellite cell is increasing day by day because now people know that these are the cells which causes the regeneration. It is the incorporation of these cells in the myofibers, which is very helpful in the regeneration. This is the plasma membrane. There is a lot of duplication of the plasma membrane. So basal lamina, sometimes lot of duplication. This is abnormal, but it's not. It can be. It's a non-specific, and it's seen in many other conditions. This is normal. Maybe some folding, but it's a single layer of basal lamina. This is the lipofuscin. One should remember these are the some lipid vacuoles, and in between there is some dark granular material. So one should remember as a postgraduate to differentiate the many times this is given as the OSPE in the exam. So these are the different, the higher you go magnification, it may not be very helpful sometimes. There's a lot of this difficult to identify the structures. But electron microscopy alone, if we don't know the background, it's not very helpful. Sometimes, for example, here there is a lot of these, the destruction of the giant band, the streaming of the giant band. These are the cores. This is the radiating fibers from the central part. One can say this is the just like the desminopathy. If you remember the desminopathies or desmin-related myopathies. But actually, this is the case of neurogenic atrophy. These are the targetoid fiber. Now, on the HND, there is atrophy. They are angulated fiber, and when we use the term angulated, this these fibers, one diameter is larger, the other diameter is small. In the normal muscle, all diameters are almost same. There should not be more than 10% difference. So that is how we differentiate from the normal angulated fibers. And in the histochemistry, this is very, very classical in these. This will appear like the central core. And those who are not aware of these targetoid fibers, you see the central core, you don't get this very intense periphery. Here it is very intense. In the in the central core disease or multimini core disease, these are the punched out areas which are very homogeneous. So that is how. So what I mean to say that electron microscopy in isolation is of no use. We should apply everything in the muscle with the other techniques. Electron microscopy, the very useful in the metabolic disorders, congenital myopathy, mitochondrial myopathy, and nowadays some of the inflammatory myopathy, inclusion body myositis, in dermatomyositis. These are the some of the example. Many times we get the question of the role of electron microscopy in muscle diseases. So these are the broader categories where muscle electron microscopy is very, very useful. These are the mitochondria. These you get the zipper like this inclusion. These are the rods, mammalian rod. These are the phagocytic vacuole. So it is not helpful in all muscle diseases. See, this is a 8-year-old male, and he presented with the muscle weakness. This appears very normal. This is the perimysium. This is the endomysium. There is hardly any fibrosis. Only thing is there is one fiber which is smaller. So in a 8-year male, this can be passed as a normal. But when we did the myosin developmental, actually myosin developmental, myosin has different isoform. The first is the developmental, then it is at the time of birth, it is the fetal. Then after 1 year, it becomes the fast, heavy, and slow. So if the myosin developmental fibers positive myosin, which are persisting at the age of 8 years, it is very, very highly suggestive of some congenital myopathy. One should investigate accordingly. What are the other ancillary techniques which are helpful? I told that it should be all together, and some may be more helpful, some may be less helpful. This is the immunohistochemistry. This is the one can do the immunofluorescence. Immunofluorescence is much better in the muscle, but the only thing is it cannot be stored. One has to see immediately under the fluorescent microscope. That is one of the problem. Otherwise, sometimes it's very bright. And for example, this here dysferlin is reduced. So I'm not very sure whether this is actually reduced or this is secondary reduction, or there's but this case is showing some mutations. But when we did the immunofluorescence, these fibers are negative. So this is the another example where the immunohistochemistry, immunofluorescence, sequencing, all are contributing for the confirmation of the diagnosis. This is another example where the multiple techniques may be helpful. This is 18-year male. He has poor scholastic performance, cardiomyopathy, muscle weakness, and then there's maybe some vacuolation, some these lightly stained fibers, maybe some vacuoles. But when we did the immunohistochemistry, it is showing very interesting results. This is the dysferlin. Some of these are positive. There's cytoplasmic positivity. This dystrophin, which is a membranous protein, it is staining these vacuoles. Myrosin, which is a membranous protein outside the cell, this is staining some of these vacuoles. So actually, these are the autophagic vacuole with the sarcolemmal features, what we call, and these are the non-specific accumulation of some of the protein, desmin, ubiquitin, and so on. This membrane attack complex activated complement is deposited on these fibers. And when we did the LAMP2 immunohistochemistry, lysosomal membrane protein 2, this is normal. How it is staining the lysosomes, it is absent here. So actually, when we did the electron microscopy, this is the cardiac muscle actually. There's a lot of these phagocytic material. These are the lysosomes. This is the membrane and a lot of these laminated structures. This is the one of the vacuole is containing the lysosome is containing the glycogen. That was the reason people earlier was calling this disease Danon disease as a glycogen storage Pompe's type 2 disease, but it is not Pompe's. So this was a case of Danon disease is X-linked, and this patient has all three features: cardiomyopathy, muscle disease, and some intellectual disability. This is X-linked. This is another example where this young child muscle weakness, they look like the congenital myopathy. There is some fat infiltration, but hardly not much variations. This is acid phosphatase. So like there is something wrong in the lysosomes. It is positive. And these are the some of the stains where these vacuoles are positive. And the LAMP2, which was absent in the previous case, is positive. But there's a deposit of the complement on the myofibers as well as in these vacuoles. And very interestingly, in I showed you that sometime in the muscle diseases you get the duplication of the basal lamina. It may be non-specific, but in this case, there are a lot of these phagocytic vacuoles, which are in the between these duplication of these basal lamina. So something wrong in throwing the fusion of these phagocytic particles. And this is there is a disease known as X-linked myopathy with excessive autophagy. There are different variants. In this case, we got the mutations in BMA21 genes. So these are the some of the example what I'm showing that the immunohistochemistry, histochemistry, HND may not be very helpful. Electron microscopy, sequencing, all are contributing. So in muscle, all these techniques should be available whenever you are doing the muscle biopsy. The HND has no role, as I mentioned. It should be frozen most of the time, which is helpful. If you don't have the facilities, it's better to refer the uh, muscle biopsy to other higher centers. Now, coming to the inflammatory myopathy, this is another example where one can get a question. Nowadays, a lot of debate on the classification of the idiopathic inflammatory myopathies. There are some muscle diseases where you get the parasite. Muscle biopsies are not done for the diagnosis of the parasite, but sometimes these are the incidental finding. This is a cysticercus. This is the trichinella. This is the toxoplasma. This is the sarcocystis lindemanni. Sarcocystis and toxoplasma are very close differential. These are a lot of these in the sarcocystis. This is asymptomatic. Incidental finding, maybe some eosinophilia in the patient, which may be the damaging the organs. But what we get is the white, these lines. These are the divisions of the cyst, which is not in the toxoplasma. And nowadays, antibodies also available against the toxoplasma. One can apply that. This is another example where 47-year male, he presented with the muscle weakness. It was HIV negative, and there's a lot of necrosis of the muscles. So whenever there's a necrosis of the muscle, diabetes is the one cause. Sometime in the what we call the Jenkins degeneration in the typhoid, that's a misnomer. Actually, it is a necrosis, but it is a term is used as the Jenkins degeneration. But in this case, there is a, this is AFB stain. There's a lot of these intracellular organisms, and this is the electron microscopy of the same patient, which is showing these some rings. And it was a case of a microsporidium. When they investigated, there was CD4 deficiency. And this is the electron microscopy. This is the from the book. These are the rings, polar filament or polar tubes. And when they cut transversely, one can count these. And depending upon these count of these polar tubules, these pieces are characterized. So this was a, so this is one question for this, which of the following AFB positive parasite in the muscle? Hydrated cyst, toxoplasma gondii, sarcocystis, or microsporidium? I know microsporidium, I told you that is the answer. Anyone, anything else which can be positive in AFB? Actually, this is not the very right question. There should be only one answer, but I have put two. Any student in the audience? AFB positive parasite, some organ, some parts of the parasite.
Some students have answered option 1, some have answered option 4, and some have answered both.
Actually, microsporidium, I showed you that is the, but everything is positive there. See there, it's so intensely positive. There's a necrosis of the muscle, but in these parasite, it is the hooklets which are positive. Anyway, this see immune mediated, what is inflammatory.
So there is one question in the chat box that what is
Yes.
the minimum and maximum fixation time in NBF for light microscopy in muscle biopsy?
You know, I was the fixation is the same as for the any other, but I will recommend it should not be done. Formalin fixation.
Okay, sir.
Formal fixation has no role in the diagnosis. If you have a parasite, you may help, but people are not doing the muscle biopsy for the parasite. I will recommend it should be the fixed in the liquid nitrogen in a pre-cooled isopentane.
Okay, sir. Thank you, sir.
So earlier classification was polymyositis, dermatomyositis, inclusion body myositis, but there are other categories also. Then there's some granulomatous and other immune, and these are the some of the differences. Dermatomyositis can occur in the children, juvenile, as well as in the adult. Polymyositis after the age of 18, but there is a question mark nowadays for the diagnosis of polymyositis. Inclusion body myositis is after the age of 50, people say, but I'm not very sure that whether it start early. This is the only one where there is male predominance. 3 in 1, mostly the disease of male. It is a distal involvement, weakness of the hands, feet, small muscles, and thinning of the distal muscle. In the muscle biopsy, it is the characterization of the inflammatory cell infiltrate. For the polymyositis, it is a T cells, cytotoxic T cells, and they should infiltrate the muscle. They should not be outside. MSC class 1, which is absent on the normal myofibers. MSC class 1 as well as 2, both are absent, but they're upregulated in the polymyositis, especially the MSC class 1. The membrane attack complex, what is the activated complement, is absent, which is present in the dermatomyositis. And if sometime we are not sure about these regenerating fibers, one can do the CD56. It stains the regenerative fibers. It stains the satellite cells, as I mentioned, and this is sometimes very helpful for the regenerating fibers. Polymyositis, this is immune mediated, this MSC class 1, these macrophages, antigen presenting cells, these with the help of CD8 positive cells, they cross the blood-brain barriers, go to the muscles, and causes upregulation of this is the usual mechanism as for any other immune mediated. And this thing, when they go to the muscle, they release the perforin, they cause pores in the membrane. Some of the studies we carried out the major histocompatibility, they are very useful for the diagnosis. This is the dermatomyositis. Now I was told there is two peaks, and in the classically there is perifascicular atrophy. This is the perimysium. Look at the fibers which are in the periphery. They are smaller in size. They are bluish, more regenerative. The nuclei are coarse chromatin. They have the prominent nucleolus. And sometimes it is not, one can't appreciate the this perivascular atrophy. One can see the oxidative stain or the MSC class 1 and 2. The other feature is the inflammation is near to the perimysium around the blood vessels. And these blood vessels, the endothelial cells are very prominent, very plump. The reason is, I told you that there's more of vasculopathy. Look at these endothelial cells. They're very plump. So this is necrosis, infarction, as I told you, this is because of there is this thrombus in the, so because of the vasculitis, vasculopathy, there is necrosis, there can be necrosis of the muscle. MS is strongly upregulated, but the inflammation in the polymyositis or it was CD3 positive and CD8 positive, whereas it is here, it is T helper cells and B cells. That is the difference between the two. This is the membrane attack complex, which is deposited on these smaller vessels. And as I mentioned, sometimes the EM is helpful. One of the criteria for the diagnosis is the demonstration of these tubulo-reticular inclusions in the endothelial cells. Earlier, if you people remember the hairy cell leukemia, The similar tubular-reticular inclusions people used to do for the diagnosis. So these are and membrane attack complex is very helpful for the diagnosis of dermatomyositis. One can do the immunofluorescence even on the skin biopsies to demonstrate the interface myositis. Now, inclusion body myositis, as mentioned, this is inflammatory, sporadic. There's one hereditary form, but it's not the inflammatory myopathy. Both are name is resembling, but actually the hereditary one is the genetically, this is a gene defect, GNE. It is more of muscular dystrophy with rimmed vacuole. And for the diagnosis inclusion of body masses, one is the vacuoles, mitochondrial dysfunctions, and some inflammation. Now, for the diagnosis, the vacuoles are the most important, but people have done the studies where it has been shown that not more than 3% of the fibers are showing the vacuoles. So there may be some sampling errors. So this is very important feature for the diagnosis, but may be absent, missing. MSC class 1 is upregulated CD8 positive cell like the polymyositis. Now many people believe that there is no polymyositis. All those cases are either inclusion body myositis or they are the overlap myositis. These rimmed vacuoles, they are positive for MGT stain. And the one of the suspecting feature is you do the COX with SDH. And when you get the COX negative fiber, which are bluish hair, out of proportion to the age of the patient, then it is highly suspicious of inclusion body myositis. Some of the proteins, even the amyloid, one of the theory I mentioned is the degeneration. Even the amyloid deposit has been demonstrated in these prions. Protein has been demonstrated. So many people think that this is a more of degenerative pathology like the degenerative diseases of the brain. On the electron microscopy, these phagocytosis, these intranuclear inclusions, tubulofilamentous inclusions, they're very helpful. This is one of the case which shows these are the mitochondria. Can you see the cristae, which are circular, the fingerprint like? The mitochondria are very long. Normally, we don't get so many such a long mitochondria. So this is abnormal. Some of the mitochondria may show some these dark electron dense materials. So this because of this, people think that this is a more of a mitochondrial myopathy defect. Now, inclusion of body myositis, hereditary and sporadic. Age, the sporadic is after the age of 50, hereditary is in the younger age. Quadriceps is spared in the hereditary. In the sporadic, it is a distal inflammation is absent. MSC class 1 is not upregulated. So as I mentioned that this is more of the gene defect is GNE, whereas this is more of the inflammation, autoimmune. Sometimes muscle biopsies are helpful. This is a case of polyarterite ankylosa. There is fibrinoid necrosis. This is granulomas, sarcoidosis. Sometimes one may get the lot of macrophages. And as I mentioned that the concept of long time back, we did the study. At the time, we published that 60% of polymyositis, but now it is a reversal. For the last 5-6 years, I have not seen any case of polymyositis classical. Either they are inclusion body myositis or they are the overlap myositis, because now the muscle specific antibodies are available. This can be tested. So the concept is changing. Now the another addition to the idiopathic inflammatory myopathy is the immune mediated necrotizing myositis. Now some of the patients who are taking statins, they present with the muscle weakness. It is very minimal inflammation. CPK is raised. and the patient has acute or subacute onset myalgia in 80% of the cases, and dysphagia and all the other neck muscle weakness, which is more common in the dermatomyositis, the polymyositis is absent. Now, there are two groups in this. One is those which are taking the statin, and there is a defect in the 3-hydroxy. This is what you call the HMGCR. These antibodies develop against these receptors, those who take the statin. But it has been demonstrated even without statin, and so now with the availability of this test, antibodies available, even these myositis, they are diagnosed in the younger children. The other group is, this is one of these. Look at these. There's hardly any defect. Maybe some these degenerating fibers. These are smaller, but there is upregulation of MSC class 1, 2, patchy, and the MAC, membrane attack complex. As I told you, this is on the muscle fiber. In dermatomyositis, we're on the blood vessels, the endomysial blood vessels, where it is mostly on the myofiber, and inflammation is very minimal. So this is one form of the MAC, membrane attack complex. As I told you, this is on the muscle fiber. In dermatomyositis, we're on the blood vessels, the endomysial blood vessels, where it is mostly on the myofiber, and inflammation is very minimal. So this is one form of immune-mediated myositis. Now there's another group which occurs in very young children, but actually it is macrophasic myositis. And the story of this disease begins when these French soldiers, they were sent to Kuwait in 90s during the invasion. They all were given this tetanus toxoid, and after that people found that there is a muscle weakness when they came back, and the muscle biopsies were done, and there's a lot of these macrophages which are positive for PAS, and it is a diastase resistant. This is the aluminium one of our case in a child, where one can demonstrate the aluminium filaments in the muscle biopsy. There is another ways to demonstrate the aluminium. But now in India, most of the cause of this macrophasic myositis is this hepatitis V vaccine, where there is aluminium in the vaccine. And this has been demonstrated even in the circulating macrophages. Some people, the children, they develop the demyelination of the brain. This is one side effect of the hepatitis V virus or the tetanus toxoid. There's another group which is the anti-synthetase disease, where it is a dermatomyositis-like picture, but there are some clinical features. There's lung involvement, there's a Raynaud phenomena, there's mechanics hand, and there's some MSC class 1 and 2 upregulation on these. Or based on the inflammatory infiltrate, now people are characterizing this, and the whether CD8 positive cells are there, whether CD4 positive cells are there, whether this is immune mediated, the therapies are decided. So this has a very important role in the therapy. Now, what are the differential of the inflammatory myopathies? This is one of the patient who has facial muscle weakness. CPK is very high. There is inflammation. So facioscapulohumeral muscular dystrophy, the one where one can get the inflammation. The other is in young children. Sometimes there's a lot of inflammations. We called it as juvenile dermatomyositis, but there was no perivascular atrophy. The MSC class 1, 2 was upregulated, very little. CD3 positive cells, CD8 positive cells, but actually later on it was found that it is showing the LMNA mutations. So this is the one lamin AC, which is a mutant, and this is the another muscular dystrophy where one gets a lot of inflammation. So one should be very careful. Number one is the facioscapulohumeral. Number two is lamin AC mutations. and sometime in dysphallopathies. So rimmed vacuoles are mostly seen in the which muscle diseases? Not seen in which of these following? Inclusion body mass sporadic, added inclusion body myositis, desminopathy, or dermatomyositis. Any clue? Which of these is not showing?
So there are variable answers. Some have answered 1, some have answered 2, and another one has answered 4, dermatomyositis.
Actually, rimmed vacuoles are not seen in dermatomyositis. All other shows these rimmed vacuoles. Though the second group is muscular dystrophy, it is a misnomer. This was used as a Greek word for the deficiency in nutrition of the muscle. But it is a heterogeneous group, genetically determined, clinically characterized the muscle weakness, wasting, hypertrophy, sometimes limb girdle muscular involvement, CPK levels are high, EMG changes are myopathic. Now, there are a lot of features which are suggestive of, for example, here, there's variation in fiber size. Some of the fibers are smaller. There is fibrosis. See, there's a lot of fibrosis. The nuclei which are moving toward the center, what we call as the internalization of nuclei. This is more of a reaction to the this injury, and this is very suggestive of the fiber. More than 3% of the fiber are showing these internalization of nuclei. It is very helpful in the diagnosis of muscular dystrophy. This is abnormal. Adipose tissue infiltration in the endomysium as in the perimysium, regenerating fiber, degenerating fibers, internalization of nuclei, split fibers. These nuclei are moving around the. This is a feature of muscular dystrophy. If it is not appreciated, sometimes the sarcolemmal membrane, these antibodies, again the sarcolemmal, they can show the this movement of the nuclei along the split. So these are all features of sometimes very lightly stained fiber. This is a degenerative fiber. If one is not sure, one can do the oxidative stain. This is absent. These some of these the fibers are destroyed. The membrane is absent, so one should not be this interpreted as a deficiency of this protein. Fragmentation of the muscle fibers. But I told you that muscle biopsy should not be near the tendons where fragmentation is common. Now, type predominance, when we use the term, normally you see this is the ATPase. The one of the fiber is not surrounded by on all around by the 5 types, similar types of fiber. When we get the one fiber which is surrounded by the 5 fibers of similar type, it is the type predominance or type grouping. In the only difference between the type grouping and type predominance is in type grouping the fibers are of the same type, whereas in the fiber predominance one may get some fibers of interspersed fiber of the other type. So these are the some of the differences within the. Now antibodies are also available, slow developmental. This I told you that at the age of at the time of birth, after 1 month, the developmental myosin is absent. The fetal disappears after the age of 1 year. It is slow and fast. And slow is type 1 fiber, fast is type 2 fibers. But in muscular dystrophy, there may be some hybrid of both these. So these are some of the muscular dystrophy. There are dystrophinopathy is the most common. Then limb girdle muscular dystrophy, Emery refers, facioscapulohumeral, oculopharyngeal, depending on which type of muscles are involved. And the large number of proteins the genes are affected. Now we have the gene mutation, we know the proteins, we have the antibodies which are available. If it is against the mutant, it will be present. If it is against the normal and there is a mutation of the gene, then this will be absent. So many people use this term as a protein minus myopathies. for this group of muscle diseases. DMD and Becker's are most common, and it's many times it's asked in the MD questions also. XP21 myopathies. The difference nowadays is only in the wheelchair dependency. If it is a patient is becoming wheelchair dependent at the age of 13, it is a DMD. If it is after the age of 13 or 6, then it is many times they know these Becker's patient, they have the normal life with little bit weakness. Many people say that night blindness is more common with the Becker's, but it's true in the Western population. I don't know why. These are the some of the signs. Gauger signs, modified Gauger sign, calf hypertrophy. These are the very helpful. This is a very large gene, 79 exons, and nowadays multiplex PCR is the very helpful. If it is not picked up by the PCR, multiplex PCR, then people are doing the muscle biopsy. Otherwise, lymphocyte is the best way to diagnose. Immunoblot can differentiate between the Becker's and DMD because this protein is totally absent in the DMD, where it is abnormal or reduced in the Becker's. This is immunohistochemistry. The different antibodies are available against the different component of the dystrophin protein rod, this amino terminal, carboxy terminal. One may be absent. The one may be absent, other may be reduced. This is the Becker's, where it is irregular staining. Some of the fibers are strongly stained, some are weakly stained, some part of the cell is stained strongly. One can differentiate between the Becker's and DMD based on the immunohistochemistry. In the carrier, one group of muscle fiber is positive, other is negative. So for carrier, it is a very good way of diagnosing. The limb girdle muscular dystrophy, the list are either they are autosomal dominant or autosomal recessive. The list is growing day by day. Earlier people said this is give the name of the gene, but now it is numbering 1, 2, 3, 4, and it has crossed the Z. So the people have started giving the numbers. Difficult to remember, but some of these have very characteristic features which one can remember in clinical practice. We did a study, calpainopathy is the most common, followed by the dysphallopathy and sarcoglycanopathy. But as in other countries, calpainopathy is the most common, and it's one of the features is some of the fibers are smaller, muscular dystrophy, fibrosis. These are some of the moth-eaten fibers, what we call the lobulated fibers. They are very classical, but they can be seen in the muscular dystrophy. These are some of these lobulated fibers. One can do the immunoblot, which is absent. One can demonstrate. Dysphallopathy is another group where it may be limb girdle type or maybe distal type, Myoshi type, but both are same. And the immunohistochemistry one can do the immunoblot, immunofluorescence, and sequencing. All are very helpful, as I mentioned earlier. Sarcoglycanopathy, more common in alpha and gamma are more common in India. They are very severe, and one can demonstrate with these antibodies. They are absent. In this is a case of gamma sarcoglycanopathy. The gamma is absent, other are reduced. So we know the muscular dystrophy easy to diagnose. We know the gene, we know the protein. If antibody is available, one can diagnose, and they the protein minus myopathy. Now, over the time, the number of biopsy, what we are getting in the earlier, it was for the DMD, BMD, but now it is for the limb girdle muscular dystrophy or the nowadays I am finding more in the inflammatory myopathies. So for the DMD, blood is the best. Lymphocytes, because muscle biopsy people say is the painful, and with the improving technology, more and more this has become cheaper. Some of the limb girdle muscular dystrophy, I think I mentioned that the most common is the calpainopathy, dysphallopathy, sarcoglycanopathy. and less common is the anoctaminopathies. Congenital muscular dystrophy, they present like the muscular dystrophy at the time of birth. This is the group of muscle diseases one should remember as a MD student, myrosin deficiency alpha. Sometimes this question is asked. Ulrich, Lamin AC, Fukuyama, these are the most common. They present with the floppy infant. They increase with they become more severe with the age, and most of the children they don't walk. Many of them are syndromic, where a lot of other can you send me this again? This is the floppy infant. The most of these congenital myopathies, the defect is extracellular proteins, matrix. They are very severe. Whereas most of the muscular dystrophy, they are either in the membrane or in the myofibrillary myopathy, it is in the cytoskeleton. This is the myrosin deficiency. Easy to diagnose muscular dystrophy at the age of 5 months. Myrosin is absent. This is the alpha dystroglycans. This is muscular dystrophy. Alpha dystroglycan is absent. This is collagen 6, which is absent. This is the control. Some of the features which are classical: rocker bottom, the heel, the torticollis, the hyperextension of the fingers. These clinical features are very, very helpful in the diagnosis, and immunohistochemistry collagen against the collagen 6 is available. But there are some other collagens, 12, 3. So congenital myopathies, I told you this is a group of muscle diseases, but they also present as a floppy infant. They are non-progressive. Central core, mini core, nominal rod, and they show the type predominance of the fibers. And one of the very important diagnoses is the electron microscopy. The rods, the cores, the immunohistochemistry is also helpful. This is the central core, centronuclear. All the nuclei are in the center. See, internalization is different where there is more than one nuclei, and they are not perfectly in the center. This is the centronuclear. Sometimes the congenital myopathy can present in the late stage, autosomal dominant, and look like the muscular dystrophy. One should be very, very careful when they present in the later age. Now, metabolic myopathies, vascular myopathy, the most common is hyper or hypokalemic periodic paralysis, glycogen storage lipid disorder, glycogen storage disorder, lipid disorder. This is one case of glycogen pompous disease. See, the pass is positive glycogen, and the glycogen membrane bound glycogen in the blood vessels, in the muscles. This is very helpful in the diagnosis. This is 11-year male, as also referral case. Lot of glycogen is positive diastase resistant, and this is a filamentous. So it is a branching enzyme deficiency. The carnitine deficiency in the young children, the lipid vacuoles, this is the electron microscopy. This is a little bit higher magnification. I told you that the lipid look like the frosted glass, opaque. This is another case I mentioned. This is a lipid storage. This is the adult. He's a doctor. He presented with the history was when he's fasting for a longer period. There is muscle weakness. And this is the wild red dough. This is the lot of lipid, and this turned out to be the long chain fatty acid metabolism defect. The mitochondria are not. There's a lot of mitochondria. They are branching. This is abnormal. Sometimes occasional mitochondria can be branching, but they are very large in size. The branching is common for different types of mitochondrial myopathy, and with this is the bluish fibers, very classical of mitochondrial myopathy. These are the oxidative stains where there is you see in the periphery SDH stain, subsarcolamellar accentuation. These are the ragged red fibers. And the mitochondrial myopathy, which present with the external ophthalmoplegia, they have very classical these inclusion in the mitochondria, zipper-like. These long parallel this parking lot, these fingerprint like, there's lipid in the mitochondria, there's glycogen in the mitochondria. And once we see these inclusions, very difficult, to, very easy to remember. The other group is neurogenic. There are a lot of causes of neurogenic, and the SMA is the most common, maybe the anterior horn cells, motor neurons, the neuromuscular junction, peripheral neuropathy. And one of the feature is a lot of these multinucleated cells, atrophic cells, group atrophy. As mentioned, that the one can do the immunohistochemistry, histochemistry. Some antibodies are available for the characterization. Now, a little bit role of NGS. It has become the, I think NGS has become very helpful in the diagnosis. Day by day, and more conditions are diagnosed. Now, muscle biopsy, should we do NGS first or the muscle biopsy? That is questionable. That is a debatable. But the one of the indication for the muscle biopsy now after NGS is the to study the pathogenesis of these diseases. For example, this is the anoctamine. We missed this as a muscular dystrophy, but when we did the NGS, we found that there are mutation in this, and this disease has there is amyloid deposit on the. We don't know the reason, but this is the muscular dystrophy where one gets the amyloid deposit. So, in isolation, is it very helpful? Now, one of the problem of morphology is, for example, this is the muscular muscle disease, muscle biopsy. There's these rim vacuoles, they are rimmed vacuoles. Now, if you look at the rimmed vacuole like this, there are many causes today. Hereditary inclusion body myositis, sporadic inclusion body M/7 myopathies, some of the calpanopathies. So now one has to see the other features. For example, the sporadic inclusion body myositis, there is inflammation. There is CD8 positive cell. In the hereditary inclusion body myositis, you don't get the inflammation. But similar changes can be seen in many diseases. And in isolation, for example, this is the core. Now, core can be seen in the central core, multimini core, in dermatomyositis, in selenoprotein myopathies. There are many causes. So, if you don't examine the muscle biopsy, these are the targetoid fibers. These are the targetoid fibers. So, on this cores can be seen in many diseases. This is the one of the features earlier. I was very sure we called as desminopathies. This is mostly seen in the desmin or desminopathy or the desmin related. But now this kinds of this is the targetoid fibers. This can be seen in many other conditions. So is morphology alone without NGS is recommended? This is very questionable. There are some diseases. I think it has stopped.
Just click in the center, Dr. Sharma. Click in the center of the screen. It will move. Click in the center of the screen. It will move.
No, this mouse is not working. After the annotation.
Annotation.
Decline, sir. Decline this.
Decline
it. Okay. So this myopapillary myopathy is a large number of myopathies which have the similar features, but it is the NGS which can demonstrate these inclusions, electromyography. They are the similar in all these. I called it as desminopathy, but this was a case of filament C mutations. So morphology alone may not be. It is a large number of maybe 12 condition in this group of muscle diseases. So can someone please tell how to differentiate between the muscle nucleus and satellite cell? I told you the basal lamina is common in the satellite cells, but the plasma membrane is different. That is the difference between the. So coming to the end, now one of the biggest problem in the classification of this was in 2011 or 12. After that, there are a lot of changes, but there's no official classification from the WHO. It has become difficult now. One of the ways protein minus myopathy, where muscular dystrophies, where gene is defected, where protein is absent. The other is protein surplus myopathy, where is aggregation of these proteins. Some of these, there's maybe non-specific sometime. There are muscle diseases where there's aberrant expression of the markers. For example, MSC class 1, 2, which is normally absent in the muscles, but is upregulated in the inflammatory myopathies. So some of those, this is one problem in the classification. The other is, for example, this is late onset, 60-year male is presented with the distal myopathy, paraproteinemia, and they were very sure this is inclusion body myositis. And there is some material in the MGT stain. When we did the electron microscopy, it is showing a lot of these rods. Is it nominal rhodomyopathy? Nominal rhodomyopathy is a congenital myopathy, young onset, but it is a 60-year. So people call it a sporadic late onset nominal myopathy where we don't know the mutations. It is not described. So these are the some of the problem in the classification. 4-year male, DMD phenotype, calf hypertrophy, CPK was 2000. Look at this muscle biopsy. This patient came from, they sent the biopsy from the private hospital. They were very sure this is a DMD, Muslim boy. But this is a lot of these muscle are empty. There are a lot of bluish material. Acid phosphatase is positive. Myrosin is positive in some of these vacuoles. And this is full of glycogen, which is membrane bound. This is Pompe's. So Pompe's disease, remember, can mimics DMD or the sarcoglycanopathies. CPK can be very high. Calf hypertrophy, which is a childhood onset. If it is infantile, it is easy to diagnose. This interval is increased. QRS complex is very high. Then the cardiomyopathies, those are easy to diagnose. But in childhood or the adult type, they're difficult to diagnose. They mimics many. This is a 40-year male, 45-year doctor. He's a surgeon, plastic surgeon. He complained that now he has started, he become tired after surgery. So he is doing surgery after sitting. Muscle biopsy was done. There's hardly any change, but look at these, some bluish material, this red material in these. This is positive for MGT, NADHDR, which is negative for the COX. So in the mitochondrial, COX should be abnormal, but it is normal, and the electron microscopy, a lot of these tubules, these are the longitudinal, these are the transversely cut double cylinders. This is the tubular aggregates myopathy. There is some defect in the calcium metabolism. So he's still doing surgery, but he's worsening day by day. So some of the conditions, very interesting, but the classification is a need of the hour now. WHO, I'm not very sure when they will come with the new classification.